Michael has a interesting educational background, I think. He did most of his, I think all of his schooling in Minnesota, University of Minnesota, Twin Cities. He did his bachelor's and then a doctorate of physical therapy, right? So he's a licensed physical therapist. And that wasn't enough for him to just have actual access to the clinic, and he did a PhD to really understand the nuts and bolts of what he wanted to investigate in his own lab. He started his lab in 2014.
That's right.
Over at Emory, so he's appointed in the Department of Physical Therapy and BME, so he's also joint appointment in biomedical engineering. And he uses a variety of different approaches, imaging, electrophysiology, and different kinds of experimental design with humans to understand the basis of motor dysfunction and how we can actively interact with humans to improve their outcomes for motor regain of motor function. So, Michael, thank you.
Thanks, Will. All right. Well, thank you for having me. Thanks to the organizers for inviting me. I'm always excited to come over to tech. I sort of feel out of place, but very happy to be around everyone. So the plan today is to, since I know it's a diverse audience, that we're going to go through a number of things. I was saying, if anyone knows this fox and hedgehog parable, I'm definitely a fox. I like to do a lot of things and like to investigate a lot of different areas rather than one area only. So we're going to go through a lot of things that the lab and I myself are very interested in terms of how we can understand how individuals move, and when they lose the ability to move, how we might be able to develop effective strategies to make them move better. I guess the other ground rules, you can interrupt me at any time. I plan to go relatively quickly because there's a number of things I'd like to show you, and of course I've put the sort of the coolest things at the end, which always, like every talk, they do that, and that's poor form. I apologize in advance, but we'll get there. So, and again, trying to be better about this, I want to make sure that I acknowledge my collaborators and the lab itself. Basically doing all of this work, I'm sort of now get to brag about a lot of the things that some of the trainees do in the lab. So let's see. Generally, we're going to go through 3 chapters today, and I'm going to point to this one because they told me that's what's on the sort of interwebs, and I will, sorry for those who are looking at this screen, you won't get the luxury of the pointer, but I think you'll be able to follow. We're going to start with very quickly talking about how we think about the conceptualization of motor skill learning and how we may be able to characterize and promote motor skill learning in healthy individuals. The second part of the talk is really going to be talking about how we use these perturbation imaging approaches, and from right off the bat, I'll tell you when we're mostly thinking about perturbation, what we're thinking about. And then the last part of the talk, we'll be talking about sort of our next frontier and how we're trying to develop better technologies to concurrently image and modulate the system. And in this case, our system is the cortex, and primarily motor cortex, but also sensory. So last second, I had to put in a video just to motivate this. So is anyone a cup stacker, competitive cup stacker? Does anyone know this field? A couple of people know it. So hopefully this will actually work. This is William Morrill. He was the record holder in cup stacking. So you'll see William here. Oh no. Hopefully it'll. So William's gonna, his job is basically to organize and sequentially stack these cups together. Yes. And so you can see he's quite good at it. He has his groupies in the back, very excited about this. He broke the record. They said he couldn't break the 5-second mark. He did it. So point is that's an impressive motor skill achievement, as you can see by the other individuals. And that didn't happen just by accident. He was not born a champion cup stacker, right? He had to learn how to actually do this. So we're going to talk a little bit, sort of at a high level, how he got to that point. So that's the first part. How we think about this is we think about that essentially any change in behavior is underpinned by memory formation that's underpinned by neuroplasticity that's induced in a specific brain region. And the most potent driver of neuroplasticity is experience. We still don't have a real drug or medicine that we can actually elicit the same degree of neuroplasticity that experience can. So if you remember anything from this talk, you've had experienced some type of neuroplastic change because you've created a memory about the information that was presented. The other thing that's important, of course, doesn't show up here for the first time of all the times, which is typical talk, which is great because then I can do fill in the blanks. So these are the stages of memory formation, and we're really going to focus on this interim stage, which is consolidation. So gray box consolidation, that's the important thing. That happens after the information is acquired or encoded. And this is an important process where we can either stabilize the information that was acquired, or we can actually even show evidence of enhancing that offline after the information has been acquired. There's also things like erasure, where you forget, or there's transference, where you transfer it to another type of information, or even integrating with previously acquired information. How do we know that learning has occurred? There has to be some sort of retrieval. So we have to show time over time that there's a persistence of this information that's been acquired. And just so you know, after you retrieve, you actually have to reconsolidate the information. So that's actually an active process. It turns out that each time you retrieve a memory, you reconsolidate it, and there can be slight changes in that over time. So again, to reiterate the point, the brain adapts and reorganizes in response to experience, whether it be intensive juggling, where we see structural changes in areas that are important for visual-motor integration in the posterior parietal cortex, whether it's a mobilization after a fracture. You can actually see maladaptive changes or cortical shrinking if someone has a fracture in their arm and they're not allowed to move it for a couple weeks. This is actually going to become important later when I talk about some of the work of my graduate student Aaron King, who's actually trying to use this phenomenon to maybe boost or potentiate plasticity. And it turns out, even in individuals who have had neurologic injury, like stroke, which is our primary patient population of interest, that you can actually see reorganization as a result of the stroke, both local to where the lesion has occurred, but also into interconnected areas, and that you can modify this reorganization through experience-dependent plasticity, i.e. rehabilitation. So that's the very, very, very quick and fast start and intro. Everyone okay so far? Okay, so basically today and every day, our lab is really interested in how can we measure and modulate meaningful neuroplastic change after injury or in disease in humans in vivo, non-invasively. And our favorite way to do this is something called transcranial magnetic stimulation. Is everyone familiar, heard of transcranial magnetic stimulation? Has everyone seen it? Oh, not everyone, so hopefully now videos work. You may recognize the participant. This is Dr. Kazar, who's actually in our department as well. But what I'm doing here is I'm holding a figure of 8 coil. This is connected to basically a large capacitor. When I trigger the system, it sends an electrical current through magnetic wire. You create a magnetic field. This magnetic field passes through the skull relatively unattenuated and induces these electrical currents in the underlying tissue, in this case the motor cortex. And as you can see, when I stimulate, her arm moves or twitches. And really, the workhorse of TMS work is this MEP, or this motor evoked potential that's elicited when we stimulate the motor cortex. Yeah. Of course, TMS comes in 2 flavors. When it's applied in isolation, either single or non repetitive pulses, it's used as an investigative tool. And you can actually probe different pathways in the areas that you're stimulating, whether it be excitatory, inhibitory, intercortical circuits, or just general cortical motor excitability. If you apply it in a repetitive or pattern way, you can actually modulate the activity in the underlying area that you're stimulating. Okay. So it's 2 different areas, and we're going to talk about both during the course of this talk. And in fact, the next part of the talk and why I brought this to the forefront is that this has been used now for over 30 years really to probe cortical processing underlying behavior. Okay. So one of my favorite papers, I actually dusted off my old, speaking of the University of Minnesota, I went back and was trying to figure out why I was doing this in the first place. So I've been here now over 5 years, and you start to think about what you're actually doing and why you're doing it. And I went back and I realized that I was just fascinated by this idea that we could use this type of paradigm to probe the causal contributors to learning. And we could really find out what areas of the brain are active when during that period of memory formation that support learning. And this was a really cool study that was done way back in the early 2000s looking at using TMS in a repetitive way to try and disrupt activity in the motor cortex after an individual had trained on a certain task. In this case, a very classic serial reaction time task. And the measure of that is the skill score, which will come back, which is basically how well can you perform on a patterned sequence, a pattern element, versus a random sequence. So basically, it accounts for general motor performance improvements and looks at sequence-specific learning. And what they found is that if you apply TMS in that period after acquisition, so during the consolidation phase, you actually see a forgetting, an erasure of the memory, suggesting that the primary motor cortex is causally involved in memory consolidation for serial reaction time tasks as sequence-specific learning. Okay? Interestingly, which is not part of this talk, but another thing that I was interested in my dissertation is that sleep actually prevents this erasure from happening. So we have some rescuing capability of sleep. So of course, what I tried to do in my PhD, I tried to replicate that and look towards more goal-directed movements that might be more related to what a patient might do after their injury, such as a stroke. In this case, it was just a simple continuous tracking task where they actually had to follow a pattern that was presented on the screen. And we did the same thing. We applied low frequency or disruptive TMS after they had practiced the task, the same amount of practice time. And it turns out we do inhibit the area. We do inhibit primary motor cortex. We see enhanced inhibitory activity in that area. But we didn't see any influence on the ability to consolidate this and, in fact, even enhance this task skill. So it suggests that not all tasks are created the same, and there is a there's a sort of a individualization of what brain regions are involved in motor learning at different periods during that memory formation phase. Okay. What was interesting to us, which we followed up in subsequent studies I don't have the time to talk about today, is that the magnitude of inhibition that was experienced through the stimulation, or one might call it the effectiveness of the stimulation, was correlated with how much change in their performance there was. The more effective the stimulation, in this case, actually the better they did at a delayed retention. Okay? So that is just a sort of starting place on where we're thinking about how we can look at the stages of memory formation underlying motor learning and how we might probe the cortical contributors to that ability to learn. Now we got a little bit more excited later on thinking about, well, could we actually use stimulation to promote positive changes in cortical activity that may enhance skill learning? And so this technique we like a lot in the lab, which is called paired associative stimulation, which is now pairing single TMS pulses to the motor cortex, time-locked to a peripheral stimulus to a peripheral nerve. And in this case, the median nerve, in this case, innervating the abductor pollicis brevis in the thumb. And what you see if you do this at the right time, i.e. trying to induce what we think of as a human analog of spike timing dependent plasticity, you actually get an elevation in the excitability of the motor cortex following the stimulation. So in this case, that's what you're seeing here. Before the stimulation, these are the responses you would elicit, like you saw in the video. You see the stimulations delivered for 10 minutes or so. And after, you get this persistent elevation of responsiveness in the motor cortex following this paired stimulation paradigm. What's interesting about this, and for those of you who are studying neuroplasticity maybe at a synaptic level or not in a human level, it actually shows very similar properties to what we know in terms of classical synaptic plasticity rules. It evolves quickly. It only takes 10 minutes to induce this. It is reversible, so you can see at 24 hours it goes back to baseline. So it's not a permanent shift. It's a transient enhancement of excitability. It persists beyond stimulation. So the stimulation is completed, but we see this persistence of effect. And it follows temporal rules. If you get the timing wrong, if you have asynchronous arrival of that afferent input with the cortical stimulation, you actually see the opposite effect. You see a depression of cortical excitability. So the unanswered question that we try to answer is that if you sort of exogenously try and induce neuroplasticity using paired associative stimulation, does it have any effect on motor learning and motor performance? Right? So, and this is Jackie Palmer. She's a talented postdoc in the lab who really helped bring this sort of study to fruition. And what we see is that after we do the stimulation, and it's not really important for the purposes of this talk other than we're looking at the gray line and the dotted line, and you can see immediately after stimulation we get this heightened response in the motor cortex. We see this enhancement of excitability. So we know that we're getting some change in the activity in the region. And then after they do that, we have them actually practice on this serial reaction time task. Okay? And we look and see how their performance changes. And it turns out that the stimulation didn't have any influence on how well they could perform after the stimulation occurred. So there was no, at least in real time, evidence of a behavioral effect. What was quite exciting and fascinating to us is that we had these individuals come back 1 week later, and we just had them perform the task again. And it turns out the individuals who received the paired associative stimulation, the neuromodulation protocol, they actually showed an enhancement without any subsequent practice on the task of their ability to perform the task. Whereas the individuals who received a control stimulation paradigm, they actually show evidence of significant forgetting. So this is to suggest that these paradigms that evaluate neuromodulatory effects, it's really important to look not only at the performance within a session, but also at the retention, because again, ultimately what we're really interested in is the persistence of this change. Okay, so then that's all great, but not everyone has access to electrical stimulators, not everyone has access to transcranial magnetic stimulators, especially individuals in the clinic. So can we develop other ways that are low-cost neuromodulators that don't actually require electromagnetic induction? So we were inspired by work that was done actually in the early 2000s as well, using short bouts of arm immobilization to try and restrict sensory input and motor output. And so in this study, they had individuals immobilized for 12 hours, and then they evaluated how well they could do a pointing task. And you can see the trajectories are clearly more variable after the immobilization. And what they showed is that this was highly correlated with the change in excitability, in this case of the somatosensory area that they were targeting or think they're targeting with this immobilization condition, suggesting there may be a link between immobilization-induced neuromodulation and change in behavior. Further that's I think what's important to appreciate is that when we're talking about these TMS-based measures of excitability, these just sort of twitches in the muscle, that doesn't necessarily mean we're talking about plasticity. So the individuals in a follow-up study looked at, can you actually change the amount of plasticity you can induce with this paired associative stimulation paradigm as a function of whether or not an individual was immobilized before that. And so it turns out that if you immobilize someone and then perform PASS, you see a heightened response. So you actually see an enhancement of the PASS-like effect, and that's demonstrated here. So this would be before and after PASS, but before the immobilization condition, you can see an elevation of responsiveness. So there's a heightened excitability. Then the individuals were immobilized, and what you see is now they have them do the PASS paradigm again, and they show a further elevation that surpasses what you saw at baseline. So there seems to be sort of a bidirectional effect of plasticity induction as a function of mobilization, suggesting that these neuromodulation interventions are probably acting on similar substrates. So that's what Erin is undertaking in her graduate work right now, is actually looking at, because partly we know now that there's a neurophysiologic effect of immobilization, and there appears to be a short-term transient effect on motor performance, but we have no idea if it does anything with learning. So what she's interested in is, can we actually induce immobilization changes in excitability? Turns out that preliminary data suggests that we can, that you have a greater amount of cortical inhibition after the immobilization compared to a non-immobilization period of equivalent time. Yeah.
Since the immobilization seems to be a critical piece here, can you say a little bit more about, are they immobilized the entire time or just specific points of that?
Sure, yes. Yeah, thanks for the question. So during the immobilization, it's essentially 6 hours where they are wearing a sling and they have what's called a finger control mitt. It's actually the same mitt that's used in the constraint-induced movement therapy studies that have been shown in stroke to be sufficient to restrict input. And so they wear that continuously for 6 hours. And then we bring them back to the lab. And so they're allowed to go about their normal daily activities. They're just asked to maintain their arm in the sling and the finger control mitt the entire time. Then they take it off during, yes. But we don't allow them to do much movement when they get in. They have to be seated, and then we take the apparatus off. And so we've confirmed that that actually does reduce the amount of activity during the immobilization condition. So this is the immobilized group, and this is the non-immobilized arm and activity counts. And this is the immobilized arm, showing that we actually reduce the amount of activity in that arm. And it seems to be that there is a relationship between this reduction in activity that we see during immobilization and the amount of inhibition that we induce. So that's okay, fine. But the exciting thing, or I think the thing that has the most relevance for what we're interested in the lab is this sort of functionally relevant plasticity, is can we actually show evidence that there's a change in the amount of learning that occurs? So in this case, similar to the study paradigm before, but instead of RTMS after the stimulation, we actually have them be immobilized. And what you see at least preliminarily, is that there's an elevation of the amount of learning that occurs, or there's greater retention in the group that was immobilized after training versus the group that was not, suggesting that it might be able to augment these processes of consolidation that are occurring to potentially enhance the effect of the training intervention. Okay, so that's chapter 1. How are we doing? Time is good. Questions on that? Other questions? Yeah. Everyone's okay? Yeah.
Maybe you're gonna get to this, but do you think part of the immobilization's effect is that you control ongoing variability in a way that is sort of unconstrained in the other condition you have? Gives you a good substrate to like put the effect back into.
Yeah, so the question is, do we think that the immobilization is just changing the variability in terms of the amount of activity that one undergoes? Yeah, so that's essentially one of the sort of features of this that we think there. So it's probably not just a direct change at the synaptic level in terms of modifying the sort of the threshold for firing, but it's probably related to this idea of how much plasticity gets induced over the period of a day. Like I say, experience is a potent driver of neuroplasticity, so if an individual is not allowed to actually experience, then it's expected that you're going to not have the same, like you say, amount of variability in that experience on a person-to-person basis. But we haven't really thought about too much about how we might characterize the variability, say, or the stability in performance. So is it a trial-to-trial change? Is it that these individuals are more consistent in their performance, and that's manifest as a mean improvement, versus they're actually just better, but it's still the same amount of variability? That's something that we're thinking about and looking at. Good question. Okay, so I think that was sufficient time for you all to read this, and I don't have to go through it. Good. Okay. So part 2, now this is the part that was sort of our bread and butter in the lab and what we're really interested in as a therapist, physical therapist. I'm really interested in this is where all our work is trying to go. It's really great to be able to play with the nervous system and raise it and lower it, and all of that is quite cool. But if it doesn't meaningfully change behavior, then we're not so interested. It's just sort of a cool party trick. However, what we're really interested in is, can we actually leverage that into changing outcomes for individual patients? And so here is a video. It's a little bit old. It was actually recorded in the lab that I have now. So this is now one of our therapists, Lois Wolf, who is part of a multi-center randomized controlled trial looking at the effects of this constraint-induced movement therapy, the gold standard right now of the therapeutic interventions for individuals with post-stroke paretic arm impairment. And so what you'll see is this individual, he's just asked to try and lift up the lid to a pot with his arm that was affected by the stroke. And what she's saying is not so important. It's just watch his movement of his left arm, the stroke-affected extremity. And this is at the beginning, prior to the therapeutic intervention. So this is sort of a baseline assessment. So he clearly has difficulty performing that task due to the impairments, the residual impairments. And I should mention that this individual is well beyond the period of time where we think there is heightened recovery potential. So he's in the chronic phase of recovery after stroke. So in this individual, we call it persistent disability or persistent impairment, but it's really permanent at this point. So he's not going to see a huge amount of change just going about his daily life. And so he was enrolled in this trial, and I'll show you an after video of him momentarily. This is a big problem. You all probably have someone either in your family or friend group that has been affected by a stroke, and to varying degrees. The frightening thing is that the prevalence is expected to increase by 20%, and the medical costs are projected to triple due to the aging population. Age is a huge risk factor for stroke. The thing is, the good news is we're getting better at helping these individuals survive the stroke. So less individuals are dying after their stroke, but that means now there's more individuals who've survived that have rehabilitation needs that are going unmet because the same advances in rehabilitation and recovery have not paralleled the treatment advances in acute stroke management like TPA, for example. So what we have is an increasing number of stroke survivors who have unmet rehabilitation needs. So that's really this next chapter is how can we actually meaningfully improve recovery for these individuals post-stroke. So now I showed you this schematic a little bit earlier, and we've added a relearning piece. So not only do you have learning of new skills, but you have relearning of old skills after the stroke, which underlie this recovery of function. And again, experience is a very potent driver of that. That's how the constraint-induced movement therapy is based upon, is really dosing high doses of repetitive practice for these individuals, task-specific. So after a stroke, we see that there are not only, again, I mentioned this earlier, changes around the area of the infarct, but also in distant connected regions. Okay? And what was very exciting way back in the early 90s is that rehabilitation could actually change the brain. Before that, in terms of stroke rehabilitation, people got better sometimes they didn't. And we had really no good way of knowing what the therapy was actually doing, so we had very little idea. However, Randy Nudo's group in Kansas experimentally induced strokes in the motor cortex and looked at if you give these individuals sort of monkey rehab versus spontaneous recovery, the motor maps, if you look at electrical stimulation of the somatotopy, it's very different if a monkey had received this task-specific rehabilitative training versus if they were just allowed to spontaneously recover. However, again, these animals never got to sort of their pre-morbid levels of function, and that's really our big idea, our big goal, is how can we try and get individuals to that point. But there's a problem. This individual, stroke here, this is diffusion tensor imaging reconstructing the cortical spinal tract bilaterally. And what you can easily appreciate is that this individual had full disruption of their cortical spinal tract, meaning no matter how much reorganization happens in the cortex, there's going to be very little effect on behavior because the wiring is no longer there. So for this individual, it's very challenging. As a matter of fact, if you perform TMS on this individual, you stimulate them, no matter how hard you stimulate, no matter how many times you stimulate, you'll not see a response. Okay? And this is, again, sort of an experimental sort of verification of what we see in many of these individuals who have dense hemiplegia after the stroke because they don't have the ability, even if they are sending the signals, they're not going to make it. Not dissimilar to complete spinal cord injury. So this turns out to be an important prognostic indicator for individuals after stroke. If acutely you see an individual, this was one of the reasons actually why I went back to school to get my PhD, is I worked in an acute hospital setting and individuals would have a stroke and some of them could not move their arm that was affected by the stroke. And they would ask me, will I get movement of my arm back? And unfortunately, all I could say was, I don't know, probably not all of it. Which, if you're a patient, that's not very informative, is it? So it turns out that if you measure it, this is some work that has been developed over the years in New Zealand, that if you measure simple measures of strength of shoulder abduction and finger extension, if individuals have poor strength, you still don't know if that's because there's sort of post-stroke inflammation, so on and so forth. There's a number of factors that can be contributing to that. However, if you perform TMS on these individuals after, and you can elicit a response, so you actually do get a response here, that's a positive prognostic indicator. That suggests that the neural substrate is sufficiently intact for the signal to get from motor cortex to the periphery. And that means that you're expected to even have potentially a good outcome versus individuals, if you cannot elicit a response, you're expected to have limited or poor recovery of paretic arm function. So this is quite helpful for therapists as well as for patients and families in terms of clinical decision making, thinking about what is realistic for an individual to achieve. The challenge is that we don't know if this will actually translate to other healthcare systems. This was all developed in New Zealand, very different healthcare system. So Mary Alice Saltao da Silva is actually doing this now. In fact, as I was walking over here, the IRB approval letter came through. So that was great. So she's actually going into Emory Hospital and Grady, and is going to do this. We're going to evaluate these individuals and to see if it does actually, if using TMS can improve our ability to predict where an individual is going to be in 3-6 months after their stroke. Because again, these assessments are taken very early. And so the reason I show this table is that actually has profound implications for how you might deliver your therapy. So if an individual is expected to have complete recovery, your therapeutic intervention is going to be very different than someone who's predicted to have none or poor, right? I think that's pretty clear. So invite me back in a few years if you're interested, and actually invite Mary Alice. She'll be a better speaker too, so have her tell you all about this. Very quickly, how do we drive neuroplasticity? If we believe neuroplasticity is important for learning and the recovery function, how do we deliver it? And really how we've done it is dosing. And this is not unsurprising across this audience, that you increase the dose, you tend to increase the magnitude effect. In fact, the time-intensive nature of this intervention. So this was based on this dosing effect. So intensive rehabilitation, many, many task repetitions. And after that period of time, months of this intervention, here's the same individual. Remember, his left arm was the one affected by the stroke, and he's pretending to do a cooking show actually here, so he's very interested in cooking. I agree. So it is great, but it's still not normal, is it? It's improved. And this was hundreds of hours of practicing, of functional task-specific rehabilitation. We know from the literature that it takes thousands of movements. In pop science, you hear about this, 10,000 hour rule, right? Is that the amount of dosing to affect permanent sort of plateau-based improvement is quite high. The big problem is, in rehabilitation, we see like a fraction of that. So we're kidding ourselves in the clinical community to think that we're actually optimally driving neuroplastic change with our current interventions, right? So that identifies a problem for us from a clinical perspective. So the question is, and I think some of you in this room, if you're interested in this, you're part of the solution as well, is how can we actually augment currently best practice therapies because we know they're insufficient. So there's novel rehab technologies. I won't get into that today. Really, I want to focus on neuromodulation approaches that might be able to augment responses to training of typical therapies. So now we just update a little bit, and we talk about NIBS, or non-invasive brain stimulation, as a way to potentially augment the mechanisms of neuroplasticity to enhance memory formation, underlying skill learning, to promote recovery of function. And so this has been done for at least 20 years now, and looking at conventional paradigms like RTMS, being able to target either down-regulated, ipsilesional, or stroke-affected excitability, or down-regulate exaggerated contralesional or non-stroke-affected excitability. And this is all born out of this model that was created from early work showing that this bilateral activation patterns when individuals are trying to perform movements with their paretic arm. And so there's this idea that you have local and global cortical reorganization, that you have decreased ipsilesional and increased contralesional excitability, creating this imbalance between the hemispheres, right? And that this imbalance may in part be one of the contributors to this persistent permanent motor impairment. We know that it's mediated by these direct excitatory transcallosal projections that project onto inhibitory interneurons that then influence the pyramidal cell output. But this is the key, is that it depends on the level of impairment, that actually this imbalance may be modulated by how much impairment an individual has, and the structural reserve an individual demonstrates. So the point here is that a stroke is a stroke is a stroke, that this model is only so good as who it fits, and it doesn't fit everyone. So we're trying to now take a sort of homogeneous intervention, high-frequency stimulation to the motor cortex of the stroke-affected hemisphere in all of these individuals. And the red is where their stroke occurred, different sizes, different locations. We are, I think, a bit naive to suggest that that is actually going to be a one-size-fits-all approach that's going to positively modulate neuroplasticity and augment responses to therapies. And in fact, we showed this some years ago now, is that we did a study, looked at this conventional one-size-fits-all, you have to start somewhere, conventional one-size-fits-all approach to upregulating ipsilesional excitability, this time in the somatosensory cortex, not motor cortex, so we at least to try to get out of motor cortex. And it turns out that in the active stimulation group, individuals generally improved in their ability to perform the task, but you can see there's variability, right? Some showed remarkable sort of effects and responses, and some showed pretty minimal and even maybe slightly no effect at all. And it turns out that this variability could be explained, about 72% of it, in how much gray and white matter volume you had in the underlying tissue that you were trying to stimulate. And that was only found in the active stimulation group. There was no association in the sham stimulation group, further suggesting that this is related to the effects of the stimulation. Seems pretty intuitive. If you don't have the substrate to stimulate, it's hard to get a stimulation effect. So we've further gone on to try and, again, think about these ways we might be more sophisticated about individualizing neuromodulation to induce positive neuroplastic change. We've shown that greater hemispheric coherence, or this connectivity between the motor cortical regions, is enhanced after stroke, and that it seems to be a state-dependent effect. We only see this exaggerated sort of coherence, or this connecting between the hemispheres, when they're active, when they're actually producing a movement. In this case, it was just a very simple sustained contraction. Okay. And it appears that there's a link between this exaggerated interhemispheric inhibition and the amount of impairment they have. Lower scores, more impairment; higher values, more coherence between the hemispheres. Okay. So question is this a new potential biomarker to target? It fits with this interhemispheric imbalance model. We're able to actually directly measure how much activity is occurring between the hemispheres. It seems to be associated with the amount of impairment an individual has. It, to us, comes across as promising. Skeptical in the audience may not, and that's great. I'd love to hear more actually about that. So we wondered, is there a more promising neuromodulation strategy than just simply stimulating the same region in everyone and just that single focal region? So we went back in the literature, looked, and we found evidence where you can actually apply TMS to the motor cortex bilaterally in a similar spike timing dependent plasticity paradigm, where you're trying to optimize synchronous pre and post synaptic. Again, this is very hand wavy because we're at the systems level, right? We're not looking at individual synapses, but at generally at a systems level, can we actually synchronize pre and post synaptic activity? And this is as actually shown in healthy individuals about 10 years ago now, to actually have an effect on not only the excitability in the target hemisphere. It increases the excitability, that's important to remember, in the target hemisphere, but it also modifies the amount of interaction, or the amount of inhibition between the hemispheres. Okay? Further, on the target, the hand contralateral to the target stimulation, they actually show improvement in motor performance. And this is all in young, healthy individuals. So our goal was to try and translate that into individuals post-stroke. So we essentially emulated the same exact paradigm. The only thing we changed, at least at the outset, was the population to be studied. But then, since we know that plasticity induction and spike timing plasticity timing is crucial, we found evidence in the literature that actually if you don't get the timing right, you get an opposite effect. So simply by shifting the timing by 10 milliseconds in terms of pairing stimulation between two cortical regions, not dissimilar to what we were attempting to do, can actually reverse the plasticity that's induced. So basically the opposite of what one would hypothesize, or an anti-Hebbian plasticity effect if you don't have the timing correct. That scared us a little bit, given that we know that after stroke, individuals show varying levels of structural change. So we've actually shown previously that there's reduced myelin, for example, in individuals post-stroke. Well, if there's reduced myelin, one would presume that there could be changes in signal conduction between regions. So with that knowledge, and with this work in healthy individuals, we decided to go about trying to individualize the stimulation interval between the two pulses, what we call the conditioning pulse and the target pulse, to try and optimize the arrival, or to optimize the synchronous pairing of these stimuli for each individual patient. Okay? So this is our sort of first attempt at individualization of neuromodulation. And these are just examples of the timing between the stimuli and looking at in individuals where we elicit the maximal response, or the maximal amount of inhibition, and using that interval then to guide the stimulation delivery. Okay? Versus, so normally the standard, i.e. one group, the standard is 8 milliseconds between the two stimuli. In these two individuals, what we saw based on the maximal effect, it would be 10 milliseconds. More clear for the individual with stroke than the able-bodied individual. And when we do that, when we actually individualize compared to that standard 8 millisecond interval, we see a heightened effect. And we see the majority of individuals show a greater response to the individualized condition versus the standard condition. Yeah. Well,
for the range of individualization, is it in the same range as the previous slide? It's like plus or minus 50 milliseconds?
Yeah, so the question is the range of individualization. So we limited it to what we know sort of from just the conduction time, that anything before 5 milliseconds is not possible. And then outside of, say, 25 milliseconds, now you're engaging potentially other pathways in this inhibitory process. So we limited it to between this 5 to 25 millisecond interval for this case. Once you get outside of that, it gets a little bit murky on what you're actually. So this, we think, is directly transclosely mediated inhibition. And so then the last thing I want to show you is another just example, is that when we individualize, not only do we get a heightened neuromodulatory effect in terms of changes in excitability in the ipsilegional cortex, we also get a stronger effect on behavior. So individuals, after they received the individualized intervention, showed enhanced skill to a greater extent that received the standard. They still improved with the standard compared to a sham stimulation, but to a greater extent with the individualized. So we're actually following up on this now in a larger cohort to see if these are stable and they are retained over time. This was just 30 minutes after the stimulation. Okay. And so we've done this quite a lot. I won't go into all the details. Suffice it to say, that's sort of the main goal when we're trying to look at stimulation or NIBS-related paradigms to modulate activity as a way to maybe potentiate the recovery of function post-stroke. Okay? So I hope I've convinced you to some extent that non-invasive brain stimulation can be an assessment tool to evaluate post-stroke changes in excitability and connectivity, actually, and that it could be used potentially as a promising neuromodulation tool if you take into account all the challenges as it relates to what we know as precision medicine. Okay? So we're going into the last chapter, and this is going to be a whirlwind. I can see the attention levels waning substantially, which is understandable. That was a lot. So this is like the 10-second regroup, because this might be the coolest part, I think. So if you don't care about stroke rehab, you can come back in now. Okay, so all these great things about TMS. Oh, it's so awesome. We use it all the time, but it's limited. And in fact, we've known it's been limited since the day it started, right? We're trying to say something about cortical excitability by measuring EMG in a muscle, right? There's already a problem there, right? So we're saying this peak, right, this peak-to-peak amplitude tells us about cortical excitability. Very, very amazing, elegant work in the early 90s actually localized the effects of stimulation to the cortex to some extent. Not fully, but we still have to appreciate that there is going to be spinal excitability influences, changes at the level of the muscle, position of the muscle actually changing, stretch receptor activities, so on and so forth. So there's a number of factors that can influence this and make it not a one-to-one assessment of excitability. The other problem is we can only elicit a peripheral response from a select number of cortical regions. So if you don't care about the motor cortex, TMS really isn't for you. If you don't care about the visual cortex, TMS really isn't totally for you. Okay? If you really care about cortical connectivity, as say a graph theoretical approach, for example, TMS really isn't for you, right? Because we can only stimulate one or two regions at a time. So we thought we were really optimizing the technique by adding 2 coils. Some other groups usurped us and did 3 coils, but that's about as far as it's gone in terms of focal stimulation. But to appreciate the network level of interactions, it's really difficult for TMS to do that as terms of a probe. So our solution is not the only solution. There are a number of solutions, but our solution to address a number of these limitations is to combine TMS with EEG in real time. So this concurrent integration of TMS with EEG to be able to not only stimulate, say, the motor cortex and measure responses from the peripheral muscle, we can also measure responses from the adjacent region, but also we get responses in distant regions. And we can actually measure that through space and time. So for those of you, very quickly, again, EEG measuring cortical dynamics. So this is also a benefit that we can actually measure elicited activity directly from the region that we're stimulating. Okay? And I've shown you this. What we do is we actually localize the anatomical region that we want to stimulate. And so now it doesn't have to be motor cortex. It can be anywhere. You can do posterior parietal cortex. You can do temporal cortex, dorsolateral prefrontal cortex. Doesn't quite matter, and actually helps if you put someone in the scanner and you get their anatomical image. You can use standard M&I coordinates to try and find the exact spot that you want to target. So now the options for stimulation location have really sort of manifest balloon mushroom. And what we do when we stimulate is all I want you to see here is just this is stimulating over the left motor cortex, stimulating over the right motor cortex, and the difference between the two. And the idea here is that we get a very rich sort of output of spatiotemporal dynamics that we know exactly when the input was delivered, and we can measure actually that input travel throughout the system. Okay? And so you can see at 30 milliseconds, the responses are quite different, localized sort of on the fronto-central locations, versus at 60 milliseconds, it now appears to be more lateralized. And this, we can actually do a lot of fancy things to try and get into what this means and what that signal propagation over time actually is telling us. But now we've at least opened the door to be able to have a new tool to assess cortical connectivity in health and in disease in response to training, looking at it over periods of time. But this is sort of where we are going as a lab in terms of what we're looking at and characterizing neuroplasticity. And so we've done that after stroke. We've shown that actually directly by direct stimulation responses. I showed you earlier TMS evoked coherence is different after stroke. We've actually looked at sort of the analog, the EEG analog of MEPs, so this TEP, and we see that the profile of this evoked response from cortical regions directly is actually also different. So we confirmed that what we would expect, but now we have the data to show that, and that it seems to be correlated with persistent impairment in chronic stroke. Okay. So our goal really is to measure cortical connectivity in stroke to be able to probe and really characterize these complex spatiotemporal dynamics and have a really strong time lock probe to be able to do that, to have these event-related dynamics rather than trying to characterize this over sort of a period of time, say at rest or during an activity. We can actually input signal and watch it move, right? And importantly, we can measure it in the time domain or in the frequency domain. So we can look at oscillatory activity, like I mentioned before, looking at what we think of as information propagation throughout the system, or we can just look at how reactive a given area is to, say, get a sense of the level of damage to that area. Okay? So we're doing that. The other sort of ongoing projects, Jackie's actually doing this to look at the lower extremity. So all of what I've talked about today in stroke has been the upper extremity. However, there's a lot of balance impairments, decreased ability to walk after stroke. And so Jackie's really leading the way on trying to figure out how we could use this concurrent TMS EEG approach to be able to understand the cortical substrates of the walking dysfunction post-stroke. And then we're doing some fancy modeling with some collaborators out at UCSD to try and, again, model this signal propagation of the TMS evoked response. So what do I think is the clinical promise? So again, I hope I've already said this, but really the key also with EEG is that we can measure responses on biologically relevant timescales. So we can, in theory, get a real-time output or readout of cortical connectivity using this approach. So we know when things start, and we have, again, millisecond resolution on our signal. We may be able to actually figure out changes in that spatiotemporal domain unique to a specific condition. We can also look at different brain states. Some really elegant work showed very early on that if you try and do TMS evoked EEG to an individual who's in the minimally conscious state, you get a very different output than an individual who's healthy. And then very, very exciting is now flipping it and using EEG to guide when we stimulate. So the idea here would be we see X brain state, stimulate. We see Y brain state, don't stimulate. So we can actually, and this has been done now in a lab, Christoph Zenner and Uwe Siemann have done this, and showed that if, depending on if you stimulate on an up state or a down state of the mu rhythm, you get very different effects. So again, going back to earlier on, this conventional one location, just do it at one frequency, that's, I think, a bit antiquated. I think this is sort of the future, is being able to use an individual's own brain signal, not too dissimilar to BCI approaches, to try and guide how we modulate the system, to be more effective in modulating the system. And then lastly, just that ability to probe non-motor circuits. So to be able to understand circuits that are not usually investigated with standalone TMS. And then last but not least, I have to give a plug to Lena and her former graduate student, now postdoc Aiden, who are working with Jackie to now I've talked about top-down. I've always said that I'm a self-proclaimed brainist. I'm really like about the brain, and that's what I focus on. But they've developed this very elegant paradigm to use the balanced perturbation platform to now induce a perturbation from the bottom up. So and Jackie is measuring, and Aiden, are measuring these evoked EEG responses to this to try and evaluate what we see in terms of cortical control of balance post-stroke. We have very little idea of any control that's involved, but we do see a signal. And as a matter of fact, Jackie's doing some nice work that she's currently in the process of writing a grant for, is looking at localizing these evoked responses to a balance perturbation in the brain to specific cortical regions and seeing if those evoked responses differ in their anatomical location as a way to try and understand this reorganization post-stroke and where we might identify new therapeutic targets or new regions that we might want to intervene rather than, again, these classical motor cortex here, or maybe it's the motor cortex for patient A, maybe it's the prefrontal sort of premotor cortex area for patient B. And now we have this, at least a way to increase the parameter space on how we might individualize or develop precision medicine-based interventions to help our individuals after stroke. So with that, I'll just close and say I think that, again, I hope I've convinced you to some extent that although there's a lot of challenges that still need to be addressed, I think that characterizing and positively augmenting neuroplasticity does hold promise for improving movement ability, both in health and disease. Of course, I'm more interested in disease, but this could also be used for regular human augmentation in terms of performance. And that we have these now non-invasive perturbation imaging tools that allow us to get a really sophisticated window into what's happening beneath the hood. So again, there's a lot of limitations of human subjects research. There's a lot of challenges with trying to characterize neuroplasticity and cortical excitability at a systems level. But these, I think, improvements in the tools that we have available allows us to ask better questions and get better answers now. And I think narrowing the gap between sort of the very elegant basic science work and some more of our applied human neuroscience work. And then I think also, it doesn't just have to be, when I think about perturbation imaging, this last year has really opened my eyes to think that perturbation can be a number of things, whether it's immobilization. We are actually perturbing the normal system by having an individual wear a sling all day and not allowing them to actually interact with their environment normally. Or is it just a very brief perturbation of their balance that causes them a short-term loss of their balance, and we can actually measure the neural dynamics of that. So I think it's a really exciting time to open up how we can use these perturbation imaging approaches to understand the cortical contributions to movement. And so I did live up to the title, even though I didn't think I would in the end. So with that, I'll put up the collaborators again, and thanks to all of them for their input, the funding agencies, our research participants, and members of the lab, again, some of which are in the audience. Thank you for coming, not just for the free lunch, hopefully. And I want to thank you all for your attention. I'll take any questions in our last bit of time. Yes.
So particularly EEG data collection, there need to be a baseline theory. And I assume the TMS kind of did a big current or magnetic injection to that region. So how do you guys in detail deal with that?
Yeah, so the question is, when you stimulate, you induce a huge electrical artifact, for one, in the simulation. And so one way we deal with that is hardware, actually, that we can now get return to baseline activity within about 5 milliseconds after the stimulation is delivered. So we can get what we would consider physiologic signal within 5 milliseconds after that. But we also look at pre-post simulation to see if there are actually underlying changes in the EEG signal that may or may not be related to the TMS pulse itself.
What I'm really referring to is afterwards, it takes us some time to recover. Like after the TMS, it takes time to recover to the state.
Right.
So what algorithm do you use to adjust?
So that's good. So the actual induced activity. So that's actually what we're really interested in is, right, the induced sort of this phase-locked activity that's elicited by the TMS to see this reactivity change. And so we know from animal work and from some other very nice work that these responses last about 200 milliseconds And so we look in that time window to really see this focal, at least in the area that's focally stimulated, right? The other propagation can last longer in other cortical regions, but within the region, so local to the site of stimulation, we look at that first 200 milliseconds to evaluate the TMS evoked reactivity, so looking at this phase lock. But there are ways that you can, like you say, look at it outside of that to see if there's a persistent effect or compare that period of time to sort of pre-stimulus activity, but that's really what we're sort of interested in, yeah. We do, yeah. So in some ways, it might be considered sort of an exogenous activation of the, but it's really what we're focused on. Yeah. Good question. Yeah. No.
You mentioned this could be used beyond stroke. What kinds of things would you think it'd be really useful for?
Yeah, so, and in terms of this, I assume you mean sort of perturbation, the multimodal things. Yeah, so especially one of the ways, and some colleagues at Medical University in South Carolina are using this approach to use what we call EEG-informed TMS for drug-resistant depression. So in dorsolateral prefrontal cortex, looking at different rhythms and only stimulating when you see sort of what we might consider the aberrant rhythm to try and do this phase resetting, for example. So that's just one, I think, really sort of obvious example, but you can imagine sort of translating that into any number of neurologic disorders where you at least have a cortical substrate, although we know that stimulation is going to indirectly affect subcortical tissue. Really, when we're talking about sort of using EEG, for example, to guide stimulation delivery, we're really interested in the cortical sort of activity. And so any, the other one that has been talked about, I don't know if anyone's really doing it, but it's looking at even in ADHD or in other reasons that are considered disorders of connectivity. And looking at trying to identify sort of the prime node of that connectivity and trying to essentially disrupt it to reset the system in a sense. So those are just a few of the ways that I think this approach is being investigated or kind of developed in the field.
People using it to enhance function in normal people, like I'm imagining with the motor responses you showed, are athletes doing this to?
Well, there are, yeah, they are, and that's sort of I should have added the caveat with this. The other thing is that I say yes, we do all these things, but the magnitude effect actually of just stimulation alone is quite transient, quite small. So if we just do, for example, we've never had a trial that we've done, if we just do stimulation alone, that we see a persistent change in behavior. So it requires that pairing or that synergistic application with an actual experience. So the stimulation alone doesn't seem to do much for that. There are some, there is some reasonable evidence showing, like, for example, using transcranial direct current stimulation while someone is doing a cognitive task, if you hit the right area, that you can see sort of in the moment improvements in performance, but then, so that's what's gotten this sort of augmentation, the stimulation, and, you can wear it during your test and you're gonna do better. And of course, it brings up all the other issues is where do you stimulate, how much do you stimulate, and so at this point it's totally unadvisable for anyone to try and use any kind of stimulation on their own to try and augment their performance. You might augment it, but it's not at all certain that it'll be for the good.
Let's thank Michael again.
There you go.